overview about this disease, prostate cancer. And to my right over here, who we have as a panel, we have Mr. Lawrence. All right, he's a prostate cancer survivor and one of our ambassadors for this evening. Also to my right, we have Dr. Simone from the Urology of Virginia. And we also have Dr. Dara Holder. Okay? So, for the first question, and I would like to address it to Dr. Simone, what is the survival rate, or how is it affected with early detection versus metastatic or late stage?
Can't hear you.
Can't hear you?
The door. Just close the door.
Can you hear me? Can you hear me now? Is that better?
Yeah, a little bit.
Okay, I'll probably speak up. So,
Can you guys hear me okay? I'm going to use my theater voice.
There you go.
Okay.
Theater voice.
I'm
Good.
projecting.
You pass the mic to you.
I don't know, do I need the mic?
That would help.
Probably if the door opens again.
Okay, all right, let me ask this question again to Dr. Sobel. All right, what is the survival rate with early detection versus metastatic or late stages? Like,
So I would say that one of the most important things to understand is that prostate cancer is a very different disease. So let's just take the word vehicle, for instance. Okay? Can you guys hear me?
Yeah.
Right. So it's a very different disease. It may have the same word. We call it prostate cancer, but it's actually a large group of very different diseases. So if you, for instance, take the word vehicle. So a cruise ship is a vehicle, right? A motorcycle is a vehicle too. But those two things are very different. So even though they're both vehicles, we really need to look at what kind of prostate cancer. So if you look at low-risk prostate cancer, that's a kind that actually can't even spread. The recommendation is to actually do nothing. Because if you look at people who had radiation or surgery or did nothing, 10 years later, 99% are still alive. So why would you choose a treatment that has side effects when you can just watch it? Whereas on the other hand, if you have an aggressive form of prostate cancer and it's caught late and it's unfortunately already spread to lymph node or bone, that could be a fairly different process. That's an incurable disease. We have great treatments to allow men to live longer, potentially 5 years, even 10 years, even when it's already spread. But that's not a situation that's curable. The prostate cancer is caught early, the cure rate is in the high 90s. If it's caught late, we're down at a very lower number. So it really just it depends on the numbers, the type of prostate cancer that you have, and at what stage it's caught. So certainly the sooner the better, the earlier the better. But it doesn't mean that all prostate cancers need to be treated. It's really important to remember that, because some people who get a diagnosis of what's called low-risk prostate cancer, they go, they see the doctor, and we talk about it, and we say, sir, Mr. Jones, you have prostate cancer, but you don't need to treat it. We have a whole conversation, and the side effects are worse than the treatment. Best thing to do is let's just watch it, come back and see us every 3 to 6 months. We'll get another picture of your prostate, get another blood test, do a finger exam, come home, they talk to their wife, they said, what did the doctor say? So the doctor said I had cancer, and I shouldn't do anything about it. The next thing that happens is a phone call from the wife. So it's important for folks to understand that every disease is different. So what's going on with your neighbor or your friend or your family member may be very different from what's going on with you. But it's always good to know what's going on, and I think that's the earlier the better.
Basically, you're saying that no one size fits all.
That's right.
we will have questions. We'll have questions for the panel. So it's a question for Dr. Holder. When should someone be screened or not screened?
So I think, can everyone hear me okay? So when it comes to screening, there is sort of the general population, and there are people who have a higher risk because of either their family history of prostate cancers or other cancers that can be linked genetically to prostate cancer. For your average patient, sort of coming off the street, American, the recommendation is anywhere between 50 to 55. For people at higher risk, whether or not that be someone who has a first-degree relative, a brother or a father, who's diagnosed with prostate cancer, generally in the earlier decades, the 50s or 60s, or someone who has a first-degree relative with a higher risk category of prostate cancer, you can move that down 10 years from when that relative was diagnosed. And I think, starting the process, the screening process is relatively benign. You come in, you do the blood test, we do the finger in the bottom test. We're able to establish sort of your risk profile and then come up with the screening pattern from there. More information is always beneficial.
Thank you very much. Dr. So, how does family history and ethnicity affect a person's risk?
So family history is important. We always ask that question. So the important thing to know, because when we ask, oftentimes we'll start to hear about your friend's brother's uncle. That one doesn't matter. But brothers and fathers. So if you have a brother, blood-related brother or father that had prostate cancer, was diagnosed with prostate cancer, that increases your risk. About 2 times or 4 times as much, depending on whether it's brother or father. What was the other question?
Oh, ethnicity.
Oh, yeah. And black men tend to have a higher rate of prostate cancer, and the kind of prostate cancer they have tends to be a little bit more aggressive. It doesn't typically change what we do with the diagnosis. Once we have a diagnosis, it's like we know way more information already. We already know the biopsy and the categorization. Like we already know, is it a cruise ship, is it a motorcycle? That earlier discussion we talked about. But in the decision making of should we get another blood test, should we get a picture of your prostate with an MRI, should we do a biopsy, sometimes that plays a role. That family history and race does play a role. We're more likely to test for it because it's a higher prevalence in that community.
Thank you, Dr. So, and on the lines of ethnicity, we'd like for us to hear from our ambassador, Mr. Lawrence. Mr. Lawrence, can you talk about your experience, about your diagnosis?
Can you all hear me? Matter of fact, let me stand up. My name is Lawrence Davis. I'm a resident of Portsmouth, class of IC North 1964. I had a father who had prostate cancer, and he thought, well, okay, man, I can fight, I can do all of this and everything else, I'm fine. And I hadn't even gotten into the point of thinking about myself. Then I started research about it, and that was in December the 2nd of 2013. March the 3rd in 2014, I was going back up to New York to bury her. I learned a lot about prostate cancer, and like most men, when they told me I had prostate cancer, and they told me on April Fool's Day, I thought it was the biggest joke in the world. Nah, y'all got to be crazy. First thing I did, like most men, I grabbed my genitals. Oh my God, because I didn't throw the ego out the door. We as men, you guys know, we got egos like all outdoors, don't we? Yes, you know that. Matter of fact, we don't even know if Moses was sitting up on Mount Sinai drinking that yak, talking to the brothers about 10. You know, but our ego is like that. But I tell all of you, as well as wives, girlfriends, significant others on the side and all that, let's throw the ego out the door. Well, after I found out I had prostate cancer, it was like, yes, it hit me just like that. I was like, oh my gosh, what am I going to do? And I started researching. As the young man, he was saying, you know, there's a difference between a ship and a motorcycle, but there's still a form of transportation. And so I started researching about, like most men, oh man, I don't want to be cut, man, I've been this, I've been that, okay, I don't want to go back to the war and all of this stuff. So I found a lot of information and did most of my research on proton. Found out that it was He was very nerve sparing, and therefore I still have that tingling sensation when the erection happened. I found out that a few other things too, that it would bypass some of the organs, and I was fine with that. So I go along and I go ahead and have that taken care of, and it has done well for me. It has done well for me. There are a lot of different manners that a few different manners that you can utilize, as the young man has said. As far as cancer is concerned, I chose proton, and it did well for me. You can even do what he was saying, I think they call it active surveillance, where you can watch it over a period of time. Like most men, yes, I was like, oh heck, suppose it started moving, and then they can't do nothing about it until another 6 months. It's not like TV. You see somebody on TV, they get shot, and all of a sudden, boom, they're in the ER, and they've got this and that and so on. Or either someone find out they have a disease and they go all around the world and everything else, and it doesn't work like that in life. So it has done very well for me. I enjoy being able to be here now, to be able to speak to you at 78 years old in a few months. And they told me I may have about 5 years, possibly a good 10 years. Well, the heck, 10 years have passed and I'm still here. The best is yet to come. Okay? The best is yet to come. And we're blessed in this area here that we have hospital facilities, medical facilities rather, like Centara, okay, and the Proton Center, and a few others, to be able to offer you a world-class type of medical taking care of your body, as well as your mind. Because one of the things I found out with prostate cancer, boy, I need to throw the ego out the door, because it does play with your mind. And I want to thank all the wives, the sisters, and the other females that actually are our support providers. Okay. A lot of us, well, I'm a man, the heck, man. I didn't do this myself. No. And you forgot to mention something about your provider. Okay. It's just like that chicken and that rooster back there you see that I have. And it always goes be everywhere. And people wonder, well, what's up with the chicken and the rooster? Well, it's very simple. Very, very simple. And you should think of the same way. That chicken is telling that rooster that if you in turn want to be the head rooster in this barnyard, you better get your prostate checked. Always remember that. Okay? We think sexually before we go out the door and think about anything else. And I'm a man like the rest of you, and I understand because I've been that way, done that, okay? And I have to be in control of myself and to say, well, okay, now let me set this aside. But I want to thank all of you all for coming in here and for listening to what we have to say. And there's only one life to a customer. The best is yet to come. Take care of yourself now, because nobody gets out alive. Nobody. Even my Lord and Savior, when they put him up on a cross, they stuck him in his side until all his blood ran out. Okay. Nobody gets out alive. I want you all to please take care of yourself. Thank you.
All right, so our next question, directed to Dr. Holder. Are there any things someone can do to prevent prostate cancer?
So, when it comes to genetic susceptibility, whether or not, it's in your genes to a certain extent, no. But there are preventing sort of the modifiable behaviors that increase your risk of cancer, such as smoking, a diet that's carcinogenic, so heavy in fatty foods or processed foods that can be poor for your overall health. But in general, there's nothing you can do, or there's nothing you're doing that's causing prostate cancer. I think at the end of the day, it's detecting it early and sort of figuring out what your next steps are. If in general you're looking to improve your prostate health, you want to make sure that you have a heart-healthy diet. I generally turn my patients towards a more Mediterranean diet, high in antioxidants, fruits, vegetables. And if you're a smoker, we talk about ceasing that behavior and any other behaviors that are just going to increase your risk of cancer overall. And it's not just prostate cancer. There's lung cancer and other cancers we treat that have a lot of risk factors that, you can just adjust by sort of lifestyle changes. But at the end of the day, a diagnosis isn't anything you did, and that's the important thing.
May I say something about that?
Absolutely.
One of the things that one should consider. Now, we make mistakes in a lot of things. Some things we say, well, I can get over that. Some things we can't. In my point of view, in life, you are what you eat. Don't ever forget that. You are what you eat. You eat junk, you're going to have junk. How can this body, which was made to move one way, or move a positive way, continue to be positive if you're eating negative stuff? Throw the ego out the door, as I always say. Okay? Learn to eat better. It's a lifestyle. It's not a diet, it's a lifestyle. My point of view, first three letters of diet is D-I-E. I'm not eating to live, I'm not living to eat. But lifestyle, L-I-V, life, and I want to live. So I'm telling you guys, continue to look at what you eat, because you are what you eat, and eat very positive. Now, some things you're going to change. Man, I like fried chicken. Yes, I do. I love fried chicken. I love pork chops too. Man, shoot, ain't nothing like some doggone gravy and some mashed potatoes. And well, you can do these things in moderation. My mother used to, one time, she used to fix me some cream of wheat. I don't know if you all know about what cream of wheat is, but anyway, it was in the morning, it was nice, and the butter was in there, and I would dig in the middle, and she said, no, start on the edge. Work your way to the center. Well, life is like that. It's not always what you love or what you think you love is going to keep you here. But do, in turn, look at your eating style.
Thank you. Thank you. Question for Dr. So, what are some symptoms, and if a person doesn't have any symptoms, what are recommendations?
So unfortunately, prostate cancer typically doesn't present with symptoms, and that's the hard part. That's why screening is important. So if you're having symptoms of prostate cancer, it could be things like difficulty urinating, blood in the urine, weight loss, bone pain. But if it's any of those things, oftentimes that's already fairly advanced. That's going to be aggressive disease. So there's really no way to catch early disease, the kind of disease that we can find, diagnose, cure, unless you see a physician or a provider. And two things that are very important, and I'm going to use your quote here, throw your ego out the door. But the finger exam, I know it's uncomfortable. I'm a urologist. I don't like doing it either, I'll be honest, but it's really important. And it's not just a blood test, it's the finger exam and the blood test, because sometimes the blood test will miss things that the finger exam will find, and vice versa. The finger exam may be normal, the blood test may then start a process where you identify it. There's a lot of overlap in the symptoms that kind of described, urinary symptoms, slow stream, frequency, urgency, getting up at night, blood in the urine, those urinary tract infections, that can come from prostate problems that are likely not cancer. That's called BPH, or just an enlarged prostate where you have difficulty passing your urine because it's growing. That's usually a benign process, not a cancerous process. But what's really important is not ignoring those symptoms, because getting in, being seen, what will happen, the first thing we do is, well, we know you probably don't have cancer, but we're going to check for it anyway. And then we're going to say, well, you don't have prostate cancer, great. Now let's work on your urinary symptoms and improve your quality of life from your enlarged prostate. But if you ignore all your symptoms, and men especially have this sort of, I call it I'm fine syndrome. I'm fine, I'm fine. And then you're not fine. So if you feel like you're having trouble passing your urine, first of all, you're probably okay. You probably don't have cancer, but still see someone. Get it checked, because then you'll be reassured with a simple finger exam and a blood test that you don't have prostate cancer. Or at least your risk is low. So that's what I would just say. Don't ignore your symptoms and let the doctor evaluate you.
And that's a good thing.
Absolutely.
That's a good thing, because we as men, we don't go to the doctor unless something's falling off or hurting. Okay? I've been, like I said, I'm a man, and I've been through all of that too. And I haven't changed over to be a woman yet either. But I'm still a man, okay? And I understand, all right? But see, if we, my point of view, love our ladies as much as we say we do, or either the enjoyment of our ladies as much as we say we do, we should realize my point of view in just camaraderie and sympathy that let's go get ourselves checked. Like the doctor says here, it's because you're taking yourself, basically you're coming to get yourself checked regularly. Prostate cancer has no symptoms. My father was in December of 2013. Oh, he thought he was fine, man. I could do this and that. And I saw him in the hospital and everything. And in March the 3rd, I was going up to bury him. Okay? Prostate cancer has no symptoms. But your doctor and or medical staff that you have working with you can look at things and say, well, okay, we can rule this out, we can rule that out. This is what we probably have, as the young man said, about you may have what they call benign prostate, which is, matter of fact, but it's a place to start. Because I've known men to have a PSA of 102, and they didn't have prostate cancer. Okay. But it's a place to start. So there's something wrong somewhere. All right. We don't go to doctors and say, oh, doctor, give me my 6 month checkup or my 1 year checkup or even my 5 year checkup until something's falling off. If we knew, and a lot of us do, but it's our ego. Let's throw it out the door. With our mother, our daughter, our wives, even your woman on the side go through for a pap smear, you tell the doctor to give you 2 fingers rather than 1, because that's the most invasive thing around. You know, and they care for you, they love you, they want you to be here. Okay, so continue to get yourself taken care of. Continue to check, okay, because hey, how can you be a king without a queen?
That's right, amen. Okay, now, at this point, I know that we have some questions for the audience. Okay, the gentleman in the back with the hat on.
Yeah, you mentioned something about enlarged, right? And if somebody's getting that treated, does it ever go back to normal, or they have to get treated for the rest of their life?
Dr. Holder?
Okay. So if you're getting getting your enlarged prostate treated. So the issue is, over the course of your life, your prostate's going to continue to grow. As it gets larger, I tell people to think of it as a donut. So as it gets larger, the donut circumference can get bigger, but at the same time, the donut hole can get smaller. When we're treating it with medications, we're trying to sort of manage that with medications. We're not curing it, we're managing it. When we're treating it with surgery, we're basically getting rid of that tiny hole, making it bigger, whether or not that be removal of most of that sort of adenoma, benign, non-cancerous process, or if we're carving out a bigger hole so that when you urinate you can do better. But it's not going to go back to the way you were when you were 20 with medications or with surgery. We're just helping you to sort of artificially get there. We're trying to make the donut hole bigger so you have a bigger tunnel to get through.
Thank you.
May I say something about that? Absolutely. I guess y'all figuring the heck, man, got a lot to say. Yeah. And I'm not a doctor, please don't think I'm in. Okay. But I can tell you from my experience and from those that I have worked with, and I've worked with people all the way from Boston down to Slidell, Louisiana, trying to get them to, especially men, take care of your health. One, there are multiple things that can be your issue, and your medical team or medical person working with you should give you options. Those options get a second and a third opinion. Okay, as we men know, the heck, we're chicken as hell. Okay, so like the heck, throw the ego out the door. Let's get a second opinion. Somebody says, like I had a young man down in Raleigh, North Carolina, and they wanted to go. He was having an issue with his prostate, and they wanted to, because he was like, oh my gosh, I can't take a piss. Oh wow, and it's bothered me so much that he didn't get a second opinion. He went wrong with the opinion to go up his rectum and to ream it out. Okay. Found out after then that the heck, that wasn't the issue. It was something else. Always get a second opinion. All right. We guys, yeah, we chicken is all outdoors. But just like, well, we're roosters big time. But like that hen back there sells that roost over there. If you want to be the head rooster in this barnyard, get your prostate checked. First time and second opinion also. Because she wants to be happy. Okay, thank you.
Yes, ma'am. I know that you had your hand up.
Yeah, I'm like this gentleman right here. I haven't converted to a man yet, so I'm not a man, but I do have a question. With everything that's being done for prostate cancer, because I have 3 brothers that have had prostate cancer, and they've all had surgery and things of that nature. But with the medication and the surgery, are there any alternative methods that's being looked into or has been looked into that's being offered, or is it just strictly medication and surgery and nothing in between?
Dr. Toby?
Yeah, I mean, prostate cancer is the most common cancer in men, but thankfully not the most common cancer killer. So it's a combination of a lot of the disease is not very aggressive, but also we do a pretty good job of treating it. But the side effects have always been the main issue. And right now, there's no solutions, there's only trade-offs. Other way to say that. There's no free lunch. There's no such thing as prostate cancer treatment that have 0 side effects. But it's a gradation, a spectrum. And to answer your question, yeah, we have traditional surgery. Now traditional surgery has now become minimally invasive robotic surgery, whereas 20, 30 years ago it was a big incision, longer hospital stay. So now it's, you're leaving the same day or maybe leaving the next day, catheter, the tube in the penis that stays in for about a week instead of 2 weeks, less risk of bleeding. So, I mean, it's still a surgery though, something to go through. And then there's a substantial recovery. There's a risk of leakage, there's a risk of erectile dysfunction. Then you have various forms of radiation therapy that come about. So there's the traditional radiation, there's proton therapy, there's something called brachytherapy seeds, which are actually implanted into the prostate. They slowly release radiation. And then you have something called ablative therapy. And ablative therapy is probably the newest form, and there's a lot of work in that arena. So ablation just means destroying it. We're not going to cut it out. We're not going to shoot it with a beam. We're going to destroy it with some sort of energy. And that field is really new, and there are patients who have very low risk prostate cancer really should just be observed. They really should be observed. Because if you're getting treated for that with anything, it's too much treatment. The other way to say that, the pill is worse than the disease. So for super low risk, don't do anything. Wait for the disease to tell you when it's time to do something. For very high risk disease, like really aggressive cancer, don't mess around with new treatments. Go with traditional. Surgery and radiation sometimes is needed for those men. They need to take the prostate out and do the radiation to that area and do hormonal therapy to potentially still achieve a cure in that very high risk men. But there's this middle ground of people who have kind of a little bit aggressive, but not that aggressive, and just a little bit, but not that much. And it feels like radiation surgery is too much, so what do you do for those? And ablative therapy is really, another word for it is called focal, meaning you're really treating just a part of the prostate. We can do freezing it, so you can freeze a portion of the prostate called cryoablation. You can do, it's called HIFU, or high intensity frequency ultrasound for a portion of the prostate. You can do electroporation, which is literally electrocuting the prostate. Then there is lasers, and there's probably 5 or 6 different types that are currently under investigation. So some are a little bit older than others, so they have some good data behind it that we can say, okay, well, this works, and we studied people, and we studied them for 10 or 15 years, and we know it works pretty well. But some have just been around fairly new, so you don't want to experiment with high-risk situations. But definitely for those middle ground situations, ablation techniques are probably the newest kid on the block in terms of options that don't cause as much erectile dysfunction, don't cause as much incontinence, and can treat maybe just the cancer, but leave the rest of the prostate alone.
Okay, but what you're saying, it still entails the medication or surgery. Like I'm talking, with all the herbs, say like if someone comes and says, well, just having a very slight problem. So are there any
Well, are we talking about
oral
cancer, or are we talking about prostate enlargement?
Homeopathic.
Yeah, that's the way.
For cancer or for prostate enlargement?
Like you said, those that have that low
Yeah,
frequency.
I would say homeopathic treatment for the very low risk prostate cancer, meaning the cancer that we probably otherwise would watch, there's no good evidence for it. There's nothing that's out there that says this works. But probably doing the things that our mothers told us to do, which is exercise every day, sleep for 8 hours, don't drink, don't smoke, eat a healthy diet with lots of fresh fruits and vegetables. That makes your body so you are what you eat. I feel like we're on the same page, you really are what you eat. I mean, it's so hard to study diet in humans because everybody's all over the place. How do you get a person to do a strict diet for 5 years and then see if they get more cancer? It's like an impossible study. So, in the absence of evidence, one must use logic and reason. So, we know it's healthy. Every cell in your body is going to be healthier. And your immune system is fighting cancer cells every single day. Cancer cells occur in our body every day, and our immune system tells us. What's good for the immune system is 8 hours of sleep, fruits and vegetables, low-calorie diet. So the thinner the better. In fact, less. It's called energy toxicity. Having too much energy, taking in too much. It's hard because you eat one McDonald's meal, and that's how many calories you should be eating a whole day. But basically, do what your mama told you, and that's probably the best homeopathic treatment.
Thank you.
We got time for 1 or 2 more questions.
Okay. Well, I think you said so many different things that I could have had questions for you very early on. I'm a 12-year cancer survivor of prostate cancer. So I had the surgery that you mentioned about, which was the Da Vinci. I had it at Hopkins. And one of the questions you may mention about the donut and the hole narrowing. So I guess the question that I'm going to ask you, because I'm asking this question to bring it out to answer questions for someone else. So if you don't mind. But I go places since you go to movies, you may go out to an event, and you go to the men's restroom and the line is long. I've never known the men's bathroom to be line long, but the line is long. And you find men standing there 10 or 15 minutes. Some of these guys are younger than you, you know, and you ask that question. So I experienced that problem where the donut hole was getting small. And then I had the Da Vinci robot, and it helped me tremendously. But the side effects, I have had that long side effect. And I come back tremendously strong, but the thing about it, what you said, I caught it very, very early. My doctor said that. And the options that were given to me were the different ones, freezing it, beaming it. I didn't know about proton therapy. I don't know if those two are the same, but are there differences in those two?
Different.
And,
One's proton, one's photon.
but I chose the Da Vinci robot. And my doctor very well, you know, and to be honest with you, as you say, when you wait too long, I was at a Gleason 6, and it progressively got worse. And I had a doctor before that was diagnosing it wrong. He thought I had an enlarged prostate and was having a problem, and so we ignored it, and he focused on something else. But I happen to have a friend, and she's a female, she's a nurse, and she set me up with one of the doctors that was very, very hard to get in to see. And he had a year wait, but because of her, he saw me, and I say that to help others by me saying this. And when I came to his office, he had a lot of people in his office that had surgery already in different forms that came from other countries that he was correcting their problems after having this type of surgery. So I guess the question I want to ask you, what makes the donut hole narrow?
Are you talking about someone who still has their prostate? What makes that donut hole narrow?
Yes.
So I generally tell my patients that, you know, your prostate's like your nose and your ears. Genetically determine what size it's going to be. It probably looks like the other people in your family, and it gets larger over the course of your life. So if we have you and your friend, you're both 56, your friend could have a much smaller prostate than you. And then, so if you think about it, your friend could have a donut that's this big with a pretty wide hole, and that's where they're starting from at 56. You could have a much larger prostate, you know, this large with a tiny hole, and that's where you're starting from at 56. Over the course, you're going to be on different growth trajectories, but over time, the donut hole is going to narrow to some extent. That extent is generally related to your genetics and where you're starting from. Okay? So that is what sort of determines who ends up with. So you can have a smaller prostate and have lots of trouble urinating because the donut hole is just so tiny. You can have a bigger prostate and you can just drive a truck through it, and that person, you know. But that's, but that is, you know, it's all about finding out where you're at and then figuring out the steps to get you better, whether or not that be cancer or even something like BPH where it's, you know, yes, it's just a weak stream, yes, it's just getting up at night, but all of those things affect the quality of life, just overall.
May I add something? I would just say that it sounds like in your case you may have had both problems. So we all use different analogies, and somehow it always ends up being food related. So I use an orange analogy. So you pee through your prostate. Like the bladder is the pump, the pipe is the prostate, right? So imagine that the prostate is like an orange. In the center is the fruit, and the outside is the rind. Most prostate cancers arise in the outside, the rind of the fruit. BPH, or enlargement of the prostate, occurs in the center. Some men don't have either problem. Some men just have one problem, an enlargement of the center part that causes urinary issues, or just prostate cancer, that on the outside that needs to be treated. But some men have both problems. In fact, it happens a lot where some men will have, maybe in your case, you had difficulty urinating, an enlarged prostate, and a prostate cancer, and so that's a no-brainer. You should have had surgery. I would choose the same thing for you. I would strongly recommend it because radiation or proton would have been wrong for you. In fact, you would have been probably harmed by it. You would have stopped urinating, ended up with a catheter, probably bleeding, and then I would tell you, I can't fix it because you've already had radiation. So that's why it's really important. Every single man has both problems, or what you have to look at it. It's like multiple variables. There's a specific treatment that's right for each man. So if your friend had proton and they did great, you have to remember they probably had a smaller prostate, no urinary symptoms, and that's why they did great. If your other friend has a huge prostate, a bad blockage, and a prostate cancer, they would do terrible with proton. They need surgery because then you're killing two birds with one stone. You're removing one organ with two diseases. And then sometimes we even do a thing where surgery may not be right for you. If you're a little older, sometimes the outcomes aren't right with surgery. So we may actually first treat the blockage with the kind of a rotor-rooter procedure, let that heal, make sure everything's healed nicely, and then do proton irradiation. So it's going to be different for everybody. It's really important to remember that it depends on the details of your particular case.
Just to say to you, I had all three. So I did the aggressive. My doctor was we caught it early. He told me and I was young. I was 50 when I first detected.
One of the things that y'all were listening to you say, you got a second opinion, okay? And as I always say, I have said, all right, always get a second opinion. Sometimes you may need a third opinion, all right? Fortunately, your friend or whomever you had with a second opinion help you along the way even more. Always get a second opinion.
Before the next question, if there's anyone who does want to have a PSA screening test today, if you would come over and let us go through the paperwork with you, probably answer the last question.
For the last question,
Yeah. I just wanted to ask, how important is it for stress management doing something like this, especially when you find out, even in the early stages, that you might have a prostate cancer? And I'll tell you, I'm a heart transplant recipient, and I remember my doctors telling me my mental approach to that, being in heart failure and waiting for a new heart, was part of that battle. You know, just having the right mental attitude towards that, because the mind is a powerful thing, and it could take you there. So how important is stress management doing that?
Dr. Sobel,
So it's very important. So again, going back to what both of the gentlemen said, you know, you are what you eat, but what you ingest isn't just about your actual food, it's about your overall lifestyle. Stress as a whole can kill. Managing that in whatever form works for you can be beneficial. So whether or not that be a support group, which there are both online and in person, to sort of get through the questions that, you know, you don't necessarily want to ask your doctor, or, you know, questions that you just didn't think of when you saw them, could be beneficial. But at the end of the day, sort of knowing what you want to do and having all your questions answered will really help to relax your mind. You want to make sure that when you leave if you're diagnosed, when you leave your appointment, you know sort of what would best suit you based on your individual symptoms. Also, what your alternatives are. You should discuss with your doctor, you know, why isn't this a better option for me? Make sure that you're comfortable with that discussion when you leave. So whenever I diagnose someone with prostate cancer, I generally encourage patients to come with a loved one at that time, because half the time they do not remember. And then the other half of the time, I'm like, we're going to go over this. You're going to leave with a sheet of paper that answers these 3 questions for you. What do I have cancer? How aggressive is it? And what are my options? And then inevitably, I'm like, okay, if you have any other questions, we can do a telehealth. We can have you come in, talk to your family, write down all the questions, and we'll get through all of them. Because having those answers just relieves the stress that's associated with this. And you want to make sure that when you leave, you're happy with your decision, or you're comfortable with your decision at least. And that comes a big part for advocating for yourself and making sure that, you know, you're on board with whatever you think and you fully understand the implications of that.
So basically, then, like I said, throw the ego out the door, okay? And you want to live for quite a while and enjoy life, I mean really enjoy life, throw the ego out the door. Yeah, as you all know and I know, we got a big ego. And life is always good.
Do you have a quick question for the panel?
To either one. How do you know which method to use for your treatment and cure if you find out? Because I remember when I first discovered, I had cancer. I was at work. My father didn't have it because he's deceased. I had no one in my family I could just track to see where this came from. It was very devastating, as you said, mental health. I mean, when I learned that I had it, I did a lot of research, did a lot of reading. There was a lot of different things to tell you to do. How do you determine? And with the guidance of my doctor, he gave me all the options. We talked about each one, and I didn't know the side effects from either one, other than what he told me, and I didn't know how the outcome would be for me. When a person approaches that and they've learned something like that and have no one else to turn to, what would be? How would you approach that?
I can tell you the variables that we use. So overall health. Remember, this is generally a slow-moving disease. Sometimes the pill is worse than the disease. So the first thing we need to look at is, and this is what we're told, you open up our textbook and it says, assess a man's 10-year life expectancy. So I'm going to look at my crystal ball and I'm going to decide whether, based off, I mean, I'm being tongue-in-cheek because we can't, but we try our very best. We see that if somebody has many, many medical problems, poorly controlled diabetes, bad high blood pressure, multiple strokes, 3 blood thinners, heart does not work well, lungs don't work well, in a wheelchair, probability says that prostate cancer is not going to hurt them. And even if I know what it is, I've got to be really cautious that what I'm really worried about is that any treatment is going to harm them. It's going to take their quality and quantity and probably make it less from the treatment, not from the cancer. So overall, number one. Number two, urinary symptoms and prostate size and prostate shape. So kind of like what we talked about earlier. If you have a second problem that's already there, you've got a blockage, you're living with a catheter, you're bleeding from your prostate already because it's enlarged, etc. You're getting recurrent urinary infections. That's going to heavily influence me towards saying, well, we got to kill 2 birds with 1 stone here. We got to fix the blockage and get rid of the cancer, so that might be a surgery. Age is kind of part of that health component. Generally, younger men go for surgery more, and older men, what does that mean? It's relative, obviously, go for some form of radiation. Why? Younger men, if you're 51 and you're diagnosed with prostate cancer and you undergo some form of radiation, proton, external beam, doesn't matter what kind, you're going to be dealing with some of the long-term side effects, probably longer. So 51, let's get you at 100. For the next 49 years, your radiation problems might be accumulating, meaning radiation, the side effects get worse over time, or worse over time. Side effects from radiation get worse over time. So because of that, you're really kind of rolling the dice on a young man having any form of proton radiation, because 20, 30 years down the road, we might be looking potentially at a second cancer, like bladder cancer, colon cancer. Very rare, but it does happen. Bleeding from the bladder, scar tissue that can happen. So that's where age matters. Whereas if somebody's 77 or 78 when they're making that decision, to get them to 100 is only 22 more years. And the likelihood of them getting a problem. So I always just say, just pretend everybody's going to live to 100, that way nobody gets upset. But the math is still there. We're still doing that math in our head. The average man in America lives till about 76. That's a very hard conversation to have with somebody who's been diagnosed with prostate cancer at 74. I'm not going to say, well, look, the tables say you're only going to live for 2 more years, so don't worry about it. We don't do that. We talk about things on an individual level. So age is really important. The last one that probably is helpful is talking to men about sexual function and urinary symptoms, but really talking to men is, here are all the side effects that can happen. Here's some radiation side effects, here's some surgery side effects, here's sexual side effects. Which one are you most afraid of? Which is the thing that you're like, I really don't want that? Because with enough treatments that we have for prostate cancer, like I said, focal therapy, cryotherapy, radiation, proton, seeds, prostatectomy, we can find a way that works where we avoid the thing that you fear the most. We do a treatment that works. Yeah, we're still going to have some kind of side effects, because like I said, there's no free lunch. There's no free lunch with prostate cancer. You're going to get something, and if you don't, you're lucky. You're going to have some kind of side effect from the treatment, but it's just making sure that it's the we avoid. Somebody saying, you know what, go look at life too. I just got married. I just got remarried. We're very sexually active. I'm most afraid of getting erectile dysfunction, so we'll work around that. Or, hey, I'm an active person. I'm lifting heavy things all the time. If I leak, that's going to really impact my life. I'd like to avoid any treatment that has a leakage. Then we work around it. So it's a lot of variables, but it's hard. I think for physicians, it's probably one of the most difficult things when people say, "What would you do?" I'm like, well, I can't tell you what I'm going to do because I'm not you, and I don't have all the same. If I had exactly your things with my values, that's what I say. I say, based on my value system and your prostate anatomy, I would do this. But your doctor should, at the end of the day, assess all those things, and then still, they should give you a recommendation. It's not a lollipop shop. We're not buying radiation or surgery, strawberry or chocolate. Doctors should give recommendations. Sir, I think you should have prostatectomy for X, Y, and Z reason. You should have radiation because of A, B, C. Does that sound reasonable to you? And then we make a decision together.
Thank you so much. I'd like to thank the panel for coming in today and have taken out their time to come and speak with us. But I also would like to give a special thanks to you gentlemen in the audience for coming here today. And we have awesome questions, and we appreciate your time that you came down here. Thank you so much.
Thank you.